How's it going, guys? Difficult question for pharmacology, step 1, internal medicine surgery, 2CK. 55-year-old man underwent a lung transplant a year ago for CF. He has hypertension that's been worsening over the past year. Serum creatinine 2.1, normal range 0.7 to 1.2. Once you've hit a creatinine of 2, you've lost 90% of your renal function. Question wants to know which of the following pharmacologic agents most likely responsible for the patient's presentation. We can summarize the stem thus far as patient had a lung transplant, is on immunosuppressant therapy, has hypertension, renal insufficiency. Let's just hop to the answer choices here. Choice A, adriamycin, wrong fucking answer, aka doxorubicin. You need to know this causes dilated cardiomyopathy, okay? You do not need to know use cases for these drugs. They can just give you miscellaneous vignette. They can say it's Hodgkin. They can say patient had some sort of organ transplant. It doesn't matter, okay? But they might just say patient had, they give you a big paragraph, patient organ transplant, and has a big floppy heart, S3, big cardiac silhouette, okay, pulmonary edema, and you would just have to choose adriamycin. In this case, wrong fucking answer. Choice B, bleomycin, wrong fucking answer. Causes pulmonary fibrosis, okay? Same exact thing as adriamycin. You don't need to know use cases. It's just going to be miscellaneous, big paragraph. They're going to tell you patient has chest x-ray with reticulonodular or reticular pattern. That's very buzzy for honeycombing, the colloquialism, which means pulmonary fibrosis, okay? Dry and respiratory crackles as an example. So bleomycin, busulfan, amiodarone, methotrexate, these are drugs that can cause pulmonary fibrosis. In this case, wrong fucking answer. Choice C, cyclophosphamide, wrong fucking answer. So cyclophosphamide, it's an alkylating agent, okay? So bleomycin is also an alkylating agent, which just means it links to DNA and inhibits DNA replication. Adriamycin causes free radical formation. So cyclophosphamide is a guanine N7 alkylating agent, and you need to know it causes hemorrhagic cystitis, okay? So red urine, and you can give a drug called Mesna, which has a thiol group and SH group. It's a reducing agent that can help mitigate the toxicity associated with cyclophosphamide, help mitigate the hemorrhagic cystitis. Wrong fucking answer. Choice D, cyclosporin, correct answer. So don't really know what to tell you, all right? So cyclosporin, I want you to know that it can cause hypertension, renal insufficiency, it can cause hypertrichosis, which is increased hair growth, okay? And it can also cause gingival hyperplasia. Cyclosporin binds to cyclophilin, decreases intracellular calcineurin, decreases transcription of IL-2, which decreases your T-cell response. It's one of the highest yield immunosuppressants on USMLE. Let's just hop to the other answer choices here. Methotrexate, wrong fucking answer, dihydrofolate reductase inhibitor. So they want you to know, we can do a lengthy 40-minute discussion of every single drug here, but they want you to know that methotrexate, the two highest yield use cases for USMLE, first line DMARD for rheumatoid arthritis, and also it's the first line oral agent for psoriasis if topicals fail. Okay, so dihydrofolate reductase inhibitor, I mentioned before, can cause pulmonary fibrosis. Methotrexate can also cause hepatotoxicity and bone marrow suppression, so neutropenia, mouth ulcers. Any of these drugs can technically lead to increased risk of neutropenia, but in particular, they like methotrexate doing that. Okay, mucositis, mouth ulcers is one of the highest yield signs of neutropenia in USMLE. So you can give folinic acid, not folic acid, folinic acid, which is known as leucovorin rescue, to help mitigate the toxicity. Don't confuse that with Mesna that we said was for cyclophosphamide mitigation. Methotrexate, wrong fucking answer. Choice, I don't fucking know, A, B, C, D, E, F, rituximab, wrong fucking answer, okay? So this is going to inhibit CD20 on B cells. Now, the way that this is going to be asked on USMLE is not just the mechanism of action, they really like it, as I just said, inhibits CD20 B cells, but they want you to know that it increases risk of bacterial pneumonia. Now, they don't expect you to be like an expert where you're hyper-specific with all the findings of it. It's just they're going to list a bunch of answer choices, and you say, well, how am I supposed to know what it causes? Okay, well, what do B cells do? They mature into plasma cells. What do plasma cells do? They secrete immunoglobulins, and immunoglobulins are key for humoral immunity. Okay, they kill bacteria. So they list a bunch of answer choices, and then they have bacterial pneumonia as the answer, and you're like, well, that makes sense because you have decreased B cell function, increased risk of bacterial infections, okay, impaired humoral immunity. Rituximab, wrong fucking answer. Choice G, sirolimus, wrong fucking answer, okay? So Sirolimus and tacrolimus, similar to cyclosporin, these are going to decrease T cell function. So sirolimus is going to bind to mTOR. It's not going to decrease intracellular calcineurin. It's not nephrotoxic. It can cause dyslipidemia. Tacrolimus, similar to cyclosporin, it will decrease intracellular calcineurin, but it binds to FK506, increases risk of diabetes. Wrong fucking answer. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. And I appreciate your time. That's it.